how we're going to address these. First, I'm just going to very briefly review post-dural puncture headache, its incidence and associated factors, and some of the treatment options we have, but I'm going to focus in on epidural blood patch. We're going to talk about its mechanism of action, the best volume of blood to use, some new data regarding its efficacy, and then some new data regarding timing. And lastly, we'll talk about complications. So just as a review, in obstetric patients, the incidence of unintentional dural puncture with a large bore epidural needle is about 1.5%. Among those patients who do have an unintentional dural puncture, the risk of headache is about 52%. I know we think it's higher, it's probably not. And among those patients who get headache, the incidence of epidural blood patch is about 58%. And headache can occur without recognized unintentional dural puncture, but that occurs at a much lower rate. We all know the clinical features. It's a positional headache. It can be either frontal, occipital, or both. It's sometimes accompanied by neck and back pain, both visual and auditory disturbances, nausea, vomiting, and cranial or upper cervical nerve dysfunction. The onset is usually within 1 to 7 days. I've found really the onset's usually in our patient population probably within just a few days. The duration can be anywhere from 1 to 7 days. There are case reports in the literature, though, of these headaches lasting over a year untreated. Removal of CSF will produce a headache, but there's incomplete correlation, meaning some patients on MRI appear to have a very low ICP and a very large leak and don't have a headache, and other patients appear to have just a small decrease in ICP or a small leak and can have a very bad headache. The mechanism of the headache is that when the ICP is low, the brain can sag and there is traction on pain-sensitive meningeal structures. In addition, there's a reflex vasodilation that takes place. It's probably the body trying to restore ICP to normal, and there are perivascular stretch receptors that are pain sensitive. Regarding risk factors for development of headache, younger patients, female patients are more likely to develop headache. Body habits, it's not 100% clear. It appears that obesity may be protective against headache, but those data are probably a little bit confounded because obese patients are also more likely to have a cesarean delivery, and that's probably protective against headache. Patients who have a vaginal delivery or have prolonged pushing times are more likely to have a headache. We all know that headache is related to needle size and type. We should all be using the smallest non-cutting needle that we can. There's some data to indicate that your needle orientation, meaning if you are using a beveled needle, that may influence headache. And there's some data about loss of resistance medium, but as Dr. Siegel pointed out, those data are probably a little bit confounded, and we should probably all just stick to what we're good at. Bed rest does not seem to prevent headache. The patient may not have a headache while they're lying in bed, but the headache will come back as soon as they stand up. Dehydration can worsen headache, but if a patient's taking normal PO, forcing fluids on them will not necessarily improve the risk of headache. Abdominal binders can help prevent headache, but they're uncomfortable and therefore not popularly used. That really just leaves us with analgesics. I think many of us use combinations of what's listed up there that may or may not have caffeine. Caffeine does have a modest transient effect on headache, so it may be reasonable in patients who have a mild headache. It's probably not that reasonable in a patient whose symptoms are very severe. It does have a prolonged half-life, and postpartum patients can accumulate with repeated doses. And with IV dosing, some serious complications such as seizure and arrhythmia have been reported. Both sumatriptan and ACTH analogs have been studied, but only a lot more study is going to be necessary before we can routinely recommend the use of those agents. So that mostly leaves us here with epidural blood patch. I I found this picture on the internet, as you can guess. I like it because it's just suspended in midair there. I don't know, I usually hold on to my needle when I'm doing a blood patch, but how does a blood patch work? You can see it tamponades the intrathecal space, kind of pushes all the CSF back up in the brain where it belongs, and so it relieves some of that traction on the meninges and relieves the reflex vasodilation. This is what it looks like. This is from MRI studies. The black dots are where the blood went in. The square is the extent of the clot by spinal level, and then the larger square is just where there was any blood at all. And so the range, when you put blood into the epidural space, it spreads 3 to 6 segments. The mean was 4.6 segments, and you'll notice most of the spread is in the cephalad direction. So the take-home point is when you do a blood patch, you should do it at or below the level where the unintentional dural puncture occurred. It appears that approximately 15 to 20 cc's of blood is necessary for this tamponade effect. Again, these are MRI studies. This topic of volume of blood was looked at recently by Pesh and colleagues. He randomized patients, or the investigators randomized patients to receive either 15, 20, or 30 cc's of blood. These were obstetric patients who had an unintentional dural puncture with a large bore epidural needle. There was no difference in the overall positive effect from a blood patch. You see the numbers across the top there. But the investigators also looked at pain scores over the first 48 hours and measured the area under the pain time curve. And they did demonstrate that there was a higher area under that pain time curve in the group of patients who had only 15 cc's of blood. There didn't appear to be a difference 20 versus 30, although 30 was not tolerated by a lot of the patients assigned to that group. The authors made the conclusion that probably 20 cc's, at least based on this study, seemed to be adequate. Now it's interesting, if you look at Pesh's numbers just regarding efficacy overall, it was a minority of patients that had complete permanent relief of their headache. 67% had some degree of relief, but often after a few days, the patient's headache came back. And a third of patients had absolutely no relief at all from their first blood patch. Now these are probably different numbers than what you've been quoting to your patients for many years. And the numbers you've been quoting to your patients for many years were probably based on these two studies. But these were retrospective and included some patients who had had prophylactic patching. And so these papers probably did make these numbers look better. You can see them there. These are probably the numbers you've been quoting to your patients. So I think that we maybe need to give our patients a little bit better expectations of this procedure. Yeah, you're likely to have relief from this, but you're also likely to be back here in a few days. And in fact, up to about 31% of patients in the Pesh study needed a second blood patch. And so I think our patients need to have realistic expectations about this. So how does timing affect the efficacy of a blood patch? There are several studies out there that seem to indicate that what you hear is if you do a blood patch too early, that it won't work. But let's look a little bit more closely at these studies. They're all retrospective. They contain mixed patient populations, some male, some female, some obstetric, some not. Mix of needle types and sizes, meaning some were large bore epidural needles, some were spinal needles. And then sometimes the definition of failure was that a headache came back and the patient needed another blood patch. And we just figured out that that could be up to a third of obstetric patients, okay? All of these studies were uncontrolled. This first one demonstrated a higher failure rate if you gave the blood patch within less than 24 hours. But the obstetric patients with unintentional dural punctures, meaning the high-risk patients, a third of them were begging for their blood patch within less than a day. Whereas the non-obstetric patients who had diagnostic LPs with a smaller needle, none of them were begging for their blood patch within 24 hours. So another way to interpret these data, rather than saying, boy, don't do a blood patch within less than 24 hours because it won't work, another way to interpret these data might be to say, patients who are miserable enough to need a blood patch within less than 24 hours are in a high-risk group, and they might be the 33% that need a second blood patch. Similarly, this is the second study. It came out of 2 different institutions, and you can see there was a difference in the needle sizes. One institution used a little bit smaller needle than the other, and it turned out that the hospital that used the bigger needles, they were more likely to do their blood patches within about 48 hours. The hospital that used the smaller needles were more likely to do their blood patches within about 72 hours. So again, is it that doing blood patches early makes them not work, or is it that if you use a bigger needle, it's more likely to be a more severe syndrome and your patient's likely to develop symptoms earlier? This last study, same thing. They just looked at factors associated with lesser effects from blood patch, and they demonstrated that needle diameter was a factor associated with lesser effects, and also delaying the blood patch less than 4 days. Well, I think probably patients who don't need a blood patch until 4 days out are probably just different than patients who are asking for a blood patch within 4 days. And in fact, in fairness, the authors of this article drew that same conclusion. So the way I interpret the analogy that I use when I talk about this is I kind of compare it to using Tylenol for a headache. If you have a headache and you take Tylenol and that headache goes away, and then it comes back 6 hours later when your Tylenol wears off, do you make the conclusion that the Tylenol didn't work, or do you make the conclusion that you need another dose of Tylenol? And I certainly understand that doing a blood patch is much more invasive than just taking a Tylenol. But I'm still going to make the argument that if somebody has very severe symptoms, there may be reasons why you want to treat it, even if it's been less than 24 or 48 hours. But you should warn your patient that that may be a marker for a severe syndrome, and she should not be surprised if she's one of those 31% of patients that needs a second patch. Now, this issue of timing is to be distinguished from the issue of a prophylactic epidural blood patch. Okay? These are data that we did when I was at Northwestern. We randomized obstetric patients who had a unintentional dural puncture with an epidural needle and who subsequently had a catheter placed into the epidural space at a different spinal level. We randomized them to receive a prophylactic patch through that catheter before it was pulled out versus a sham patch. And what we demonstrated was that there was no difference in the incidence of headache overall or in the incidence of post-dural puncture headache, which was defined specifically as a postural headache. Now that is in contrast to this manuscript, which was recently published last year. These authors did in fact demonstrate, as you can see, a difference in the incidence of headache in their prophylactic, they called it therapeutic, but prophylactic versus non-prophylactic group. And they also demonstrated a difference in headache severity. Now the difference between those two studies is, in this study, in the Stein study, the investigators were not blinded to group, and also their treatment was not protocolized in any way. And so some patients got caffeine, some didn't. They got various different prophylactic and treatments. And then these unblinded investigators were also the ones deciding whether or not the patient needed a therapeutic blood patch. And so I think this study is a little bit weak. Does that explain all of these findings? Probably not, because even in our study that did not demonstrate a difference in incidence, there was a difference in the duration of the headache. The white square there to the left of your screen represents the patients who had the sham patch. You can see that their headache lasted longer than the patients to the right of the screen. And so when you measured the area under the time pain curve, the area, again, was higher in the patients who had the sham patch versus the real prophylactic patch. So if you take these two studies together, I think that there probably is some benefit to doing a prophylactic epidural blood patch, but it's probably not as dramatic as you might think if you went only by that Stein study. So this might be a technique that you might choose in your high-risk patients. And what do we mean by high risk? Somebody who's very thin, who has a vaginal delivery, who maybe pushes for 2 hours, that might be a high-risk patient. And in that patient, you might choose to offer a prophylactic patch. If you do, you should probably wait until the effects of the epidural have completely worn off before doing it. Number one, you're going to want to know if the patient is having radicular symptoms, and you're not going to be able to know that if the patient's still numb. Number two, there is this report of total spinal anesthesia following an epidural blood patch that was done while the patient was still numb from the epidural, and the hypothesis was that doing the patch kind of pushed all the local anesthetic up. Let's go through complications. The most common complication is back pain. In this PESH study, the overall incidence of back pain was 85%, so it's pretty common. There was no difference in the incidence of back pain, 15 versus 20 versus 30 cc's of blood. Most of the time, the back pain is mild and easy to treat with either heat or nonsteroidal anti-inflammatory drugs. Occasionally, it can be more severe or even associated with radicular symptoms. It's thought that if you limit your injectate, if the patient starts feeling pain or radicular symptoms, if you stop the injection at that time, that might limit some of these sequelae. It hasn't been studied really well, but it is what most clinicians recommend. Rarely, you can see lumbovertebral syndrome. You can see transient bradycardia. These have all been reported. A transient seventh cranial nerve palsy. Sometimes exacerbation of the headache. That seems to have occurred in patients in whom you didn't have the right diagnosis. That's what these case reports were. So perhaps if somebody has a headache, transiently increasing their ICP with a blood patch isn't a really good idea. Arachnoiditis has been described. You can expect, again, on these MRI studies, you can expect that there is some spread of blood from the epidural into the intrathecal space across this large 17 or 18 gauge hole. The case reports of adhesive arachnoiditis that have been reported, there was pain, great pain during injection, yet the authors still continued to make the injection. I think in general, with neuraxial anesthesia, including blood patch, if the patient is screaming, you're probably doing something wrong and you should stop, okay? Now, it seems obvious, but somehow it's not. Regarding deterioration of mental status and seizures, again, there are a handful of case reports out there, and what they seem to have in common was that the diagnosis was wrong. It turns out the patient was having a headache from another cause. So again, maybe transiently increasing ICP in patients who are having headache from whatever cause isn't really a good idea, and that's why you may see this occasionally. I want to spend the last few minutes talking about the scope of the problem. Post-dural puncture headache interferes with activities of daily living, including childcare. increases both hospital and ER visits, and increases the length of stay. In addition, it can rarely be associated with more serious complications, such as subdural hematoma or cranial nerve palsy, which, when it occurs, may not respond initially to blood patch, because the cranial nerve palsy is due to stretching and demyelination. And once that demyelination occurs, it can take months to get better, even once you treat the headache. Or I should say, once you treat the low ICP. And then these data came out just a few years ago, came out of the Columbia group. Does unintentional dural puncture with a 2E needle increase risk of chronic headache? And the answer seemed to be yes. They looked at 40 patients who had had an unintentional dural puncture, and they compared them to 40 patients in a matched cohort, and they looked for incidence of chronic headache, chronic backache, and disability from either, using validated measures, okay? And what they demonstrated was that patients who had dural puncture were more likely to suffer from chronic headache 2 years out than the matched controls who didn't suffer dural puncture. What was interesting, if you look below, it appears that blood patch may have some protective effect, that if you looked at just the 40 patients who had the punctures, the patients who didn't have a blood patch seemed to have a higher incidence of chronic headache. It did not reach statistical significance. It probably wasn't powered, because in the top slide there, we're looking at 80 patients. In the bottom one, we're looking at only the 40 who had the unintentional dural puncture. The backache data looks the same. Patients who had dural puncture were more likely to suffer from chronic back pain 2 years out compared to those who didn't have dural puncture. And interestingly, there seemed to be this non-significant but suggestion that blood patch might be protective, which is a little counterintuitive, because we think blood patches cause back pain, but blood patches may cause acute back pain. They may not. They may actually be protective against chronic back pain. Similar data for disability from either headache or back pain. Patients who suffer dural puncture are more likely to have disability from either, but again, a suggestion, it didn't reach statistical significance, that blood patch may be protective. And so I know we all think of this as a big nuisance. It's probably the biggest nuisance we deal with. Because, you know, you have these patients written up on your board, and you have to call them every day, and they come in for the blood patch, and then your nurses never really like doing the blood patches, and then they have to come back for another blood patch, and it is really a nuisance. But I think we need to think of this as more than a nuisance, at least in patients who have severe symptoms. I think I'm probably pretty aggressive about offering blood patch, and maybe not even just offering blood patch, but recommending blood patch. And I think it's based on some of the rare complications that can occur after unintentional dural puncture, and some of these data that seem to be suggestive. And so I encourage you to do the same, and I encourage you all to join us for the SOAP meeting in Colorado Springs this May. Thank you.